Good morning, good evening, good afternoon, everyone, and a very warm welcome to this ICH webinar dedicated to the role of the microbiota in hematology. Over the past decade, we have witnessed a profound shift in our understanding of human biology. The microbiota, once considered a passive bystander, has emerged as a dynamic and powerful regulator of immunity, inflammation, metabolism, and tissue homeostasis. And today, and I'm sure you will be convinced, it stands at the crossroads of immunology, oncology, and precision medicine. And in our hematology field, this represents a true new frontier. From hematopoietic stem cell transplantation to acute leukemia, multiple myeloma, lymphoma, and immune-mediated complications such as graft versus host disease, we do have mounting evidence that shows that the microbiota shapes treatment response, toxicity, infection risk, immune reconstitution, and ultimately it will impact patient outcome. So what was once invisible is now becoming measurable, actionable, and potentially targetable. At the ICH, our mission is to anticipate scientific revolutions, bridge disciplines, and translate emerging science into clinically meaningful knowledge. This webinar, you will see, perfectly embodies that ambition, because we will explore where the science truly stands, what is ready for clinical integration very soon, and what remain investigational but promising. I'm delighted to welcome top expert faculty today, namely Dr. Annalisa Ruggieri, Dr. Jaime Sanz, Dr. Florent Mallard, and last but not least, Dr. Michael Locci. And all of them are at the forefront of this rapidly expanding field. And I thank all of you for joining us today to explore what is clearly one of the most exciting and transformative area in modern hematology. So let us begin. The way it will be structured, I will present just a couple of minutes the results, small results of a survey done by the ICH about the role of microbiota modulation, and you will see the question. Then I'll ask Professor Mallard to present the currently available data we have in this field, especially in graft versus host disease. And this is coming very timely because it has been, some of the data were presented at the last ASH 2025 meeting. And this will be followed by an important round table discussion. And I'm very honored to announce that for the round table discussion, we will be joined by Professor Agnès Buzyn, who is a hematologist, has led many regulatory agencies, and is our former Minister of Health in France. And she has been much involved in the regulatory aspects when it comes to these new treatments, new biologics. And we would love to hear also from her, because there is an opinion piece from the European investigators how to consider these drugs. So without any further ado, let me share with you some of the results of the survey that was performed by the ICH, and probably many of you participated. We had more than 150 colleagues who responded. And by the way, the full results of the survey will be published hopefully soon. So here I selected only very few questions. First of all, how familiar, for instance, are you with fecal microbiotherapy? We have roughly 20% who are very familiar, 40% plus somewhat familiar. The rest of the colleagues are aware but not familiar with it. So we need to really work on making everybody familiar with fecal microbiotherapy. Have you ever been involved in fecal microbiota for any indication? Again, we do have this strong group of 20% who replied yes. They have prescribed it. They have administered it. We have 10–15% who referred patient to this. So, but again, the majority are not actually involved or treated patient. Now, regarding the indications, this is very interesting. This is very interesting because when you look into the different possible indications, it's interesting to note that, for instance, Clostridium difficile is clearly an indication, and definitely we do agree on this. Graft versus host disease is viewed by 2/3 of the responders as a clear indication. And that sounds very good because you will hear the great results that will be presented by Professor Malar. But also there are many other indications: cancer immune therapy related colitis, resistance to immune checkpoint inhibitors, neutropenic enterocolitis, multidrug resistant bacteria. So plenty of indications, I can assure you. How important do you think the gut microbiome is in modulating outcomes in hematology or oncology, example, GVHD, immunotherapy, infections? Amazing results. 70% consider this very important, so that's a good start. You are convinced, guys. Even you have the remaining 30% who consider this moderately important. And how strong is the potential for fecal microbiotherapy to become a standard component of care in hematology oncology? Again, we have the majority considering it has a high potential, 55%, moderate potential, the remaining 45%. People are really convinced. What about the patient opinion? How open are patients to receiving fecal microbiotherapy? And I was pleased to see that most 30% consider that most are open with appropriate explanation, some hesitance, but still. So we clearly need to educate and inform the patient about this innovation. And which statement best reflects your view on how fecal microbiotherapy should be prepared and delivered? And I was also very pleased to see that the majority is asking for industrial grade GMP products for consistency and safety. And we don't want all of these homemade preparations. You can't do precision medicine with whatever homemade or hospital-based products. Are you aware of any industrial drug-grade full ecosystem microbiotherapy currently being developed or used? 30% are familiar with the concept, and they mentioned the Mat Pharma product. It's called now Xervitec, the drug, and these are the results that will be presented. Somewhat 30%, I heard about them, but not very knowledgeable. And of course, we need to educate the remaining colleague. How should full and ecosystem microbiotherapy be classified within the healthcare system? Again, majority are asking for biological medicinal product or industrial grade product requiring GMP manufacturing, which actually they go together. And in the next 5 years, how do you expect the clinical use of fecal microbiotherapy in hematology oncology to evolve? And again, the majority suggest 50% rapid growth, integration in care, another 35% slow but steady adoption. So I'll stop here, and before moving to Professor Malar, maybe I can ask one word from each the panelists. What do you think about these results? I think they are good, but they highlight that we need really to raise awareness and educate about this field. I don't know, Annalisa, would you like to?
Yes, absolutely. Thank you, Mohammad. Actually, these results are very, very important, and I thank the EACH for bringing the survey and discussing about this interesting topic. And it is really important to consider the perception of the patients and the interest that all the community, the scientific community has, and the need of developing a trial and having results with this great tool for the treatment, because we will see how it is not only an immunosuppressive approach, but is an immunoregulation that is all involved. So it is really, really interesting, and I really believe we will have a very important insight with the further discussion.
Jaime?
Yes, very interesting information. And I guess it does show that the role of microbiota and the possibility of clinical use is definitely a growing field in not only hematology, but in medicine. And I'm surprised to see how excited people are and the big knowledge they have. So,
Excellent.
Good news.
Super. Thank you, Jaime. Michael?
Well, I think the data are pretty exciting because it seems that the entire community is pretty excited about it. But it underscores that we have lots of information to give about it. I was a little surprised that I would say so few colleagues are aware of the indication in GVHD, have used it in GVHD, because in France we've used it for I don't know how many years now. I think I've used it for like almost 6 to 7 years. So yeah, we have lots of to do.
Super. Okay, I will not ask Florent because he is convinced. I will kindly invite Professor Malar to share the most recent data from this field, and you will see these are really exciting results in GVHD, especially, and hopefully very soon this will be ready for routine clinical use. Florent, the floor is yours.
So thank you, Mohammad. Yes, I'm very happy to be here today to share the latest result regarding the use of microbiotherapy in the setting of graft-versus-host disease. Just to highlight that we truly have an unmet medical need when we go to the treatment of graft-versus-host disease, in particular in patients that fail both steroids and ruxolitinib. And as you can see here, we have a very long list of treatment that are used currently in the third line setting, but in fact, results are pretty disappointing. It was a study that was performed in 64 patients that failed both steroids and ruxolitinib. And as you can see here, the median survival of those patients was 28 days. We performed a similar study in Europe. So I'm going to present you here. It was a Chronos study. It was a retrospective study that we performed with Mad Pharma in Austria, Belgium, and France. So to have a good overview of the practice of Europe, we're not able to include more countries, unfortunately. It was we focus on the third line treatment. So it is truly some patients that receive steroid first line, ruxolitinib second line, that fail ruxolitinib and that receive a third line treatment. And we exclude the microbiotherapy just to have an overview of other treatment beside microbiotherapy, and it was patients that were treated recently between 2019 and 2024. Here, this is the patient characteristics. So 59 patients, so some pretty good number of patients that are enough to draw some conclusions. Here, this is the patient characteristic. This is more interesting to look at the graft-versus-host disease characteristic. And in fact, in this study, all patients have a GI involvement. So this is only patient with GI involvement. So some severe patients, lower GI for all of them. And also some of them also have some skin and liver involvement. And all patients failed steroid, ruxolitinib. It was either resistant or intolerant to the ruxolitinib. And regarding the third-line treatment, they received ECP for 17 patients, TNF-alpha inhibitors, vedolizumab, or other systemic treatment, including mesenchymal stem cell, but for only one patient. When we look at the response rate regarding the all organ response rate, so including also the skin and the liver, it was pretty poor, 36% with only 20% of complete response. When we look at the gut only, it was some pretty similar outcome. And when we look at the response, so at day 56, and in fact, the response decreased to 20%, highlighting that we don't have any sustained response in those patients. And when we look at the loss of response, we find that we have a lot of loss of response in the patients that translate into an overall a median overall survival that was slightly less than 100 days. So it's better compared to the previous retrospective study I just showed you, but still a patient that have a median overall survival of around 3 months, it's a very poor outcome for those patients. So this survey highlight that we don't have any standardized third-line treatment for graft-versus-host disease, that we have a few effective third-line treatments, and this lead us to the role of microbiotherapy in this setting and to the presentation of the phase 3 ARES study that were presented during the last ASH meeting in Orlando at the end of 2025. So here we're using this off-the-shelf GMP available product called MART13, and now, as Mohammad told, this is a Xervitec, the brand name, that is presented as a rectal suspension, and we deliver 3 doses over 10 days, day 1, day 5, day 10. This is a standardized product with a high richness, high diversity. As you can see here on the slide, when we look at the richness of the MART13 product is significantly higher compared to the use of single donors that allow us to deliver all the patients all the potentially benefic bacteria. The product is stable for 36 months, so it's already available, and we have some available data from the ARES study already published, the ARES that I will present it now, and I will present you right after the early access program that can be used in Europe, but also in US and Canada and different countries around the world, with more than 240 patients that have been treated so far. So here, this is the design of the studies. As a key inclusion criteria were adult patients, high GVHD with GI involvement, all of them that failed steroids and ruxolitinib. They were excluded, of course, in case of differential diagnosis, such as CMV colitis, if they receive additional treatment before, if there are overlap chronic graft-versus-host disease, and also patients with hyperacute graft-versus-host disease within the first 2 weeks after transplant. So we have the screening, but in fact, the screening was really shorter than that. And after the patient received the 3 doses of MART13, and we were able to evaluate the response rate. That was a primary endpoint at day 28. And we also have some additional evaluation at day 56 and 3 months on the overall survival that were evaluated at 12 months. Importantly, we assess all the response with an independent review committee just to be sure that we truly capture the right answers. Here, this is a baseline characteristic. So median age of 55 years, so pretty old patients. all were refractory to ruxolitinib, and almost all of them were steroids refractory. A few of them were steroid dependent, 40% of the patients. Most of them have severe grade 3 or 4 GI acute graft-versus-host disease. We have mainly some classical within the first 100 days after transplant acute graft-versus-host disease, but also some late onset, either post-DLI or just classic late onset. The other, in fact, it was a patient with an hyperacute graft-versus-host disease that were included, despite the fact that it should not have been included. But in fact, this is some patients that are more severe, so it will not impact the overall outcome of the study. Almost all patients received the 3 doses. In fact, the patients that were not able to receive the 3 doses of the MAT13, it is because of the fact that it is a few patients that failed the treatment before the second and the third doses. And 4 patients received a 4th doses. It is for the patient that achieve a response at day 28, and after we have a relapse of the GVHD, and we have the possibility to give an additional dose, but it was very few of them. Here, this is a response rate. This is at day 28. Here, this is for the GI overall response rate, 62%. For the all organ response rate, it's 64%. And as you can see here, it is mainly some complete response and very good partial response, highlighting that the product was effective with a median duration of response of slightly more than 6 months. And we achieved the primary endpoint, because when we compare to an historical control with an overall response rate of 22%, it was significantly better. Importantly, it is some sustained response when we look at day 56 at 3 months, so we have a slight decrease. Nevertheless, as you can see here, almost all patients that were in complete response remain in complete response, and most patients that were in very good partial response remain in very good partial response, highlighting that despite it's only a 3-dose treatment and that they don't have any additional treatment between day 28 and day 56, they remain in response. So we have some long-term effect with sustained responses. When we look at the overall survival, so the median overall survival, I just show you before with the other treatment, it was around 3 months. Here, the median overall survival was not reached. And when we look at the responding patients, we achieve significantly higher overall survival at 12 months compared to the non-responding patient. And this is a landmark analysis, so excludes the patient that died before day 28 in the non-responding group. So we truly have some data that we can trust regarding the response assessment on the correlation with the overall survivals. Regarding the safety, this is key, of course, when we are going to give some microbiome in a patient with GVHD, GI involvement that receives steroid, ruxolitinib. In fact, we have some adverse event in all but 1 patient, but this is a patient that withdrew consent right after the first dose, so we did not evaluate anything. The most common treatment emergent adverse events was Echinacea sepsis. We have also some septic shock in some patients. And in fact, the majority of the adverse events were within the 2 weeks after the last dose, and 26 of them were fatal, lead to the patient death, and only 1 of them were considered to be related to the treatment. So as expected, we have some bacteremia, we have some infectious side effect, but in fact, we know that those patients with some GI acute graft-versus-host disease already have some bacteremia, so it was some expected side effect, and we don't have any signal that would increase the risk of infectious event by using MAT13 microbiotherapy. So the overall benefit risk assessment was good. We achieved some deep and durable response rate that translate into prolonged survival in a population known for very dismal clinical outcomes, and we have an overall good tolerability of MAT13 in treatment of these severe patient populations. Beside, so I would like to thank all of the investigators that treated the patient, and of course the patient, the caregiver, and the healthy donor that provide the product to perform the MAT13s. And in addition to the RS phase 3 study, I think it's interesting also to go through the result of the early access programs in Europe. It was a result that were published that were presented during the last EHC meeting, but we have more patients than that today, but I will present this today. So regarding the MAT13, I will just skip this slide. I just present you how the drugs is working. Here, this is the inclusion criteria of the early access programs. It's steroid refractory, steroid dependent. So here we don't have to fail ruxolitinib. Patient can apply for the MAT13 product as early as the second line of treatment. But as you know, most of the time patient receive ruxolitinib as the second line. But in some patients, there may be some contraindication to ruxolitinib that can say, no, I would like to try a MAT13 as a second line of treatment. This is the case for a few of them. This is all patients with GI involvement. This is important. We have to stop the antibiotics for 12 hours before and after the administration of MAT13. This is also true for the RS study. Here, this is the patient characteristics. So mainly some steroid refractory and a few steroid dependent acute graft-versus-host disease, mainly some classical acute graft-versus-host disease, and mainly some severe grade 3 to 4 graft-versus-host disease. Here, this is a response rate, so pretty similar to the RS study, 53% at day 28, and again, some sustained response at day 56, 47%. And here, so the median overall survival was reached here with 48% overall survival at 1 year, and it was significantly better in patients that achieve a response at day 28 compared to the non-responding patients. When we focus on the 70 patients that received steroids first line, ruxolitinib second line, and MAT13 third line, so very similar population of the RS study. And here we have some very close results with 57 GI response rates. We also have some skin and liver involvement. And when we look at the all organ response rates, it's 54%. And again, the response was sustained with at day 56 for the GI response, a 57% response rate. And here we have a 51% overall survival at 1 year for all patients, and for the patient that achieve a response at day 28, the overall survival was 77%. So this is what I just show you. To conclude, we have the access program on phase 3 that are consistent and confirm the high efficacy of MAT13 for steroid-resistant and steroid-dependent GI graft-versus-host disease. We have a very good overall survival in this very severe population, and that's truly better compared to the Chronos and the other study I just show you with other third-line treatments. We have some very innovative mechanisms of action, more based on the immune modulation rather than some immunosuppressive treatment, and we expect to be able to show you by the end of the year also some microbiome and immune data that go more in detail regarding the mechanism of action of the drugs, and the overall safety is good. So again, I would like to thank all my colleagues, in particular all the work that were done just to collect the data of the early access program that allow us to present these results. And I will end here so we can have some time for the panel discussions.
Thank you very much, Florent, for this clear presentation, but also lovely results in an unmet need situation. So in order to kick off the discussion, again, I'll have a sort of a round table among our experts who are treating GVHD on a daily basis. What do they think about the results? And obviously, I would like to kindly remind the audience that you can share your questions and we will try to handle them with the panel. So, ladies first, Annalisa.
Thank you, Momad. Thank you, Florent. The data are really, really exciting because all of us are every day struggling with the very, very severe and difficult to treat GVHD, and especially those having a GI involvement, bringing the proper treatment without complication is really difficult. And both the results that you presented from the ARES trial and also for the expanded access clearly demonstrate how we have to think and to be brave in proceeding with this kind of treatment, especially considering that the rate of response is very high in patients with failing second-line treatment. So it is a really important also to stress that the steroid-sparing possibility and the fact that the burden of complication related to the long-term, also the disease control, it is very, very important to consider. And another consideration is about the safety, because of course all our patients are very immune compromised, and the flexibility of performing the treatment also without the need of like long-lasting exposure to antibiotics is very important, because often they have fever, they are still neutropenic, so it is really, really important to consider how these results help in the scenario of the GVHD. And to me, I think that this product will help all of us in being more confident in treating our patients with, and we will think on the use of fecal microbiota earlier in the lines, because it is really clear that the earlier is the best. So really thanks for these brilliant results.
Thank you, Annalisa. Jaime, you've treated many patients, including some of the patients in the early access program. And by the way, this early access program is available almost worldwide. So if someone has any patient who is in need, I think I recommend to make a request. So Jaime, what are your thoughts?
Thank you, Florent. I mean, these are spectacular results. And for me, what's striking to me is a few things. The first is the strong correlation between the data from the clinical trial, that we always think these patients are selected and sometimes without, with the real life data, both from the Chrono studies and the open access program. Results are very similar in both scenarios, and that gives very strong information, meaning that these results are probably true. And also, I think that the outcomes are better than the expectations most of us had. I mean, we all know how difficult third-line treatment of acute GI-GVHD is. I mean, any little improvement would have been great, but at least me, and I think most of our colleagues, did not expect this type of outcomes. 60% rate of remissions is quite incredible. Of course, this raises many questions now. Do we have any biological correlations? Why is it working? Also with the management, how are we going to be able to give this treatment and combine with antibiotic therapy? And I'm sure we'll discuss over the next few minutes.
Thank you, Jaime. Michael, you have also a very large experience, whether in clinical trial or in the early access program. What are your thoughts?
I think it's a real breakthrough in the treatment of gut GVHD. Obviously, the results that Florent presented are pretty amazing. It's a game changer in the treatment of GVHD. As was already said, we didn't have much option before. We have all witnessed so many patients died and failed any other treatment in steroid and Rux refractory patients. And now we have this great option. Obviously, there is a learning curve in using the drug, on when to use it, when do we do when do we ask to get it in the early access program. And what's really important to stress is that there are like these two types of patients. There is the steroid refractory and the steroid dependent. It works for both, but I think that for the steroid dependent treatment, it really allowed us to withdraw steroids for these patients. And there were patients for whom we couldn't do it before. There were patients who would remain on corticosteroids with all the infections following. And so this leads me to the safety of the drug. And this is very important. And because the drug is safe, it will probably lead to earlier use of the drug in earlier indication instead of RUX refractory. But I think we're going to talk about it a little bit later.
Thank you, Michael. So we'll take now a few questions from the audience, some practical questions. Florent, maybe you can handle this because you didn't show biology data, but we have a question from Dr. Lakota asking whether there are biological results or data which can corroborate the clinical efficacy.
So, yes, thank you for this question. As I pointed out.
And there is another question, Florent, and this is, I think, in line about the mechanism of action of immune modulation. This is Dr. Dereen.
So, yes, so see, this is some key questions. So, as pointed out, we have some biological data for the RS study, but that's not available yet. But we have some previous data from the Heracles study that were conducted before. And in fact, we're able to correlate the response with an engraftment of the MAT13 product. So in patients that achieve a response, we have an increase in the richness and the diversity of the microbiota. And in particular, we find an increase in the number of butyrate producing bacteria. This is some butyrate that have some immunoregulatory properties. So we clearly find a correlation between the biology and the achievement of the response. Next, what we need to look is at the effect at the systemic level. And we're also able to show in this study that in patients that achieve a response, we have a decrease in the pro-inflammatory parameters, a decrease in the IL-6, CRP level, and so on, in the pro-inflammatory cytokine, while we find an increase in short-chain fatty acid, on butyrate, and so on. So we truly find a systemic effect and explain why we not only have an effect on the gut graft-versus-host disease, but also achieve some response in some liver and skin graft-versus-host disease. So it's not just a local treatment, but we truly have a systemic effect, and we really expect that from the RS study, we'll be able to bring more answer regarding the immunomodulatory effect on the mechanism of action.
Excellent. Thank you very much. Maybe I can direct this question now to Michael, because we have a question about how to handle the antibiotics issue, because in the trial, that wasn't the case in the early access program, if I remember well, you had to discontinue actually the broad systemic antibiotics, but also give the vancomycin locally to prepare, I would say, the ground. Maybe, Michael, you can explain the concept.
Yes, so
from Dr. Mendes and many other colleagues.
The idea is to not destroy the microbiota graft that you're going to perform by administrating the MAT13 drug. So the idea is to have a patient who is obviously stable enough and who doesn't have an ongoing infection, so that you can remove the broad spectrum antibiotics long enough for the graft to be administered, and then for the MAT13 to be administered, and then have an effect. And then it's what we did in our center is that we decided to establish antibiotic protocols for patients who received microbiota fecal administration, so that we would try not to use toxic broad-spectrum antibiotic after the treatment, and trying to use more drugs that would not impact the gut microbiota, such as aminoglycosides, who are not going through in the lumen of the gut, and that will preserve the microbiota in the gut while acting in the blood, which I think is a strategy that should be explored.
Excellent. Thank you very much. Jaime, you can maybe handle this question because you treated a lot of patients. How long does it take to achieve a response when using, for instance, this Xervitec product?
Response are surprisingly quick. I'm not sure that I think the data was, I think Florence showed the median time to response, but I think if I remember correctly, it's about 3 days. Is that correct, Florent? So very quick responses. And of course, to be able to enter the trial, you have to have GI, GVHD. But it's also surprising how you see responses in other organs quite quickly too. So very striking, yeah, but very quick. Also,
another practical question from Dr. Yaroslava Adamasakova, I hope I am pronouncing well, is about the monitoring of these patients who are receiving the FMT enema. How do you monitor them after the administration? And by the way, the tolerance by the patient is great.
Monitoring in what sense? Clinical monitoring?
Yeah, I mean, for clinical monitoring, do we need, I don't know, we don't put them in ICU.
No.
Is there anything special, if you give CAR T cell, you have to monitor CRS, ICANS. I don't think we have to monitor anything new here.
No, these patients, as we all know, are very fragile. Really, so they're most of the times inpatient. They usually have nutritional support because they have active GI GVHD. But it's the usual clinical monitoring, and because the toxicity is very low, there's the usual monitoring of GI GVHD.
Excellent. So we have now a question, and maybe Annalisa, sorry.
I just would like to add two points. One regarding the clinical monitoring, because it is really safe. We do the procedure in the patient room and just after like the Trendelenburg to avoid early rejection of the product. But actually the patient here is really in a safe condition, and there is no early side effect. And what we have seen in our patients is we used to follow the patients with to like try to understand, because all of us are very interested in knowing how the patients could benefit of it. We performed some echography looking at the thickness of the bowel and the inflammation, actually the gut inflammation, and it was really impressive in seeing how the benefit was really not only in the extension but also in the deepening of the severity. So really a quick response, showing also, demonstrated also by easy procedure like echography, bowel echography, of course, done in our center. Just we did baseline, and then just to follow how the response, the overall response lost. But of course, there is also the clinical response that was very, very exciting.
Thank you, really, Annalisa, for sharing these new insights. And we have a question here about, well, if the results are very good in the third line and heavily pretreated patient, could this FMT product become a first-line therapy for GVHD or for prevention? And I think this is an important question, and I think we can reply here. Maybe I can share a slide and maybe Florent, you can comment on it because we do have an ongoing protocol, actually, a randomized trial from this field. Maybe some of you are participating. I don't know, Florent, can you comment on this Phoebus trial?
Yeah, for the Phoebus, we are more than the first-line treatment. This is more some prophylactic treatment. And in fact, in the Phoebus, we are no longer using MART-13, but MART-33. This is not delivered by the enema, but this is on pills. This is the same product with a similar composition, high diversity, high richness, but given as pills. It allows us to deliver the treatment at home, and in fact, patient will take the pills on a daily basis for 1 week before the start of the conditioning regimen. They will receive the halo, and after around 2 to 3 weeks, where after neutrophil recovery, they'll take again the pills for the first 100 days after the transplant. And we speculate that it will allow us not only to decrease graft-versus-host disease, but decrease the risk of infectious side effect. On the primary endpoint in this study, this is overall survival. So this is some very ambitious, but really truly need that it can be a game changing to use this microbiotherapy to improve the overall patient's outcomes.
Excellent. So this is an ongoing phase 3 randomized trial, controlled, blinded against placebo. And obviously, it's including more than 50 centers are participating in different European countries. Obviously, if you are interested, I think you should send a message. Jaime, you would like to comment?
Yes, this is a very important issue now that we've seen, I guess, like in every drug development that you test the efficacy and the safety of a certain drug in very advanced phases. Now that we've seen that it's safe and that it seems very effective, what should we do with it? So we're testing it in a clinical trial in prophylaxis, but are we, maybe we can discuss it all together. Are we thinking that this is a drug that is going to compete with other medications in first, second, third line? Or is it going to be an add-on medication or add-on product that we should add to whatever treatment, systemic treatment for GVHD? So for instance, in first line therapy, should we give or study in the future if we should add corticosteroids and these type of interventions as add-on strategies?
Thank you very much. So let's move now to the last part of the discussion. And I'm very honored and privileged to introduce Professor Agnès Buzyn, who is a hematologist by training. She used to be the head of the transplant unit at the Necker Hospital in Paris. And then she was heading different regulatory agencies and was our former Minister of Health in 2017. So we have like the double view here, the hematologist, and yes, you've seen these acute GVHD patients in the past dying, unfortunately, with little or no available options. So my first question to you, your global impression, global feeling about these results. I know you haven't treated GVHD patient in the last few years, but still, I'm sure. And then we'll discuss, because this is a new era, I mean, a new treatment and how to classify, how to handle this.
Thank you very much, Mohamed. First of all, thank you for this very clear presentation and such wonderful data. It's really impressive for second and third line therapy for refractory GVHD, and really it looks like a miracle drug. So really impressed. And I think the question of prophylaxis or treatment in first line with corticosteroid is a very good question, because with such results in second or third line, we can imagine that in first line, the results would be better. So very, very impressive. I was wondering, but you answered already, there were some surrogate markers for response biological surrogate markers, but I'm sure that you are monitoring some parameters, and I hope that you will have data. The problem with such drugs, of course, is that some teams might want to have homemade microbiota and fecal graft. So the question is, are we sure that the results would be the same with any microbiota? And the results you're showing are results which are performed with not homemade. It's really reproducible microbiota, and it's done like a drug. From a regulatory point of view and from ministers of health point of view, I think regulatory bodies would prefer homemade because it might cost less, and it might be easier to get those drugs in routine, because all ministers of health are looking for investing less and less in drugs and in therapy. So the question for all the hematology team in Europe now is, how do we monitor those fecal grafts? Can we imagine that only one type of microbiota is really useful, or any homemade can be used? I'm not sure. I think that survey and clinical research should be made now with all the team using microbiota. I'm afraid that we could face a kind of
anarchy, I would say.
Yeah, exactly. And I'm not sure that all the results would be exactly the same. So what you're showing is the kind of results and quality of data of any clinical research done with a drug. And this is really useful. So that could open the market to this drug. I'm not sure that all homemade microbiota can give exactly the same result. So this is my question. What is your feeling, Mohammed?
Well, obviously, I think you have translated this very nicely. In our field, in hematology, in cancer in general, and even beyond, I think the introduction of these novel modalities like the microbiotherapy must be accompanied by rigorous evaluation of safety. This is what has been done in clinical trials, consistency, but also traceability. So regulatory clarity is not only desirable, but I believe it is mandatory. And this is why I personally believe, and I'll ask my colleagues what they think, because they are on the ground also treating patients, is that we clearly need products, substances that fulfill all the requirement of a drug, whether we like it or not. Obviously, we all would love to do things in our lab and to develop homemade things. And I'm part of the group, but still, this is not what you would like to deliver on a larger scale to treat your patients safely, especially the GVHD patient who are highly immunocompromised. And Elisa mentioned this. And obviously, again, because of the subtle differences between the different microbiota product from different donors, this is why having a harmonized product like in this Gizervitec. So let me ask, Rhonda, Michael, would you be willing to give any kind of product to your patient?
No. So I think in this type of product, it's very important that we have reproducible data, and that only happens if you have a very well controlled industrial process. I think it would be pretty hard to rise to the standard of the actual available drug for an academic product. Had the opportunity to witness the security committee of the industrial process and all the screening they are performing to make sure that every product is safe. I don't see how it would be possible for an academic product to go that far.
Thank you, Michael. Jaime, what would you
Yeah,
be willing to
I
do?
completely agree. It's a key that we have a homogeneous product, and I think we may want to learn from the experience of mesenchymal cells, for example, that we've used many different products from different centers with different outcomes, and to date, nobody knows if they're useful or not. So I think we have to take the lesson learned.
That's a good example. I didn't think about it, but obviously you're right, Jaime. The first report about the efficacy of mesenchymal cells was from more than 20 years, I think 2004 or 2005, published in The Lancet by Katarina Leblanc. And 20 years later, because of the absence of homogeneity, definition, clear development, the role of mesenchymal cells remain, I would say, with lots of uncertainties. Annalisa, what do you think?
I agree with all of you, and especially for considering the need of rigor and really standardized process in the setting of quality and safety for the patient. So it is very important to consider that having the right product you cannot use. We are also in the setting of patients transplanted using of course another donor, so you cannot consider, oh, I would like to use FMT for the same haploidentical donor or whatever. You need to have a product that is standardized and following the compliance and the GMP process in order to be sure that the safety of the patient is ensured. So it is really, really important to have an adequate regulation in this setting to avoid the risk for the patient.
Wonderful. And by the way, when you mentioned it's needed to have a regulation, obviously 15 European experts published in BMT, the official journal of the EBMT, end of November, a position statement clearly calling for action to regulate and really allow for harmonized and safe development to ensure access in good conditions to all patients. And yes, any final comment and how do you feel the field going?
Thank you, Mohammed. I'm very impressed. I left bone marrow transplant more than 10 years ago, 12 years ago, and it has changed a lot. Many treatments now and the type of graft have changed, but I can feel that when patients develop refractory GVHD, the outcome is still very, very bad as it used to be. So bringing a new therapy with such an efficacy is really a hope, I think, for the field. And I really want to thank all the teams who participated to such a trial, because these data are very serious. It's not 10 patients. It's randomized and it's very impressive. So thank you for all of you. Maybe one day I will do bone marrow transplant again, but for the moment I'm just watching the progress. It gives a lot of hope for those patients. Thank you.
Thank you very much, Professor Brizard, for this Lovely conclusion. Actually, the microbiota is no longer a peripheral or exploratory topic in our field. It is clearly now well established in the therapeutic arena. And what we once considered as a passive ecosystem is now clearly recognized as a dynamic, biologically active organ that profoundly shapes immune homeostasis, inflammation, treatment response, and toxicity. And by the way, we had a comment from the audience suggesting that the systemic immune modulation of the microbiota may allow to decrease relapse. Actually, and I believe this is an important relapse. Obviously, looking ahead, the challenge for our community is how to integrate microbiota-based strategies into rigorous clinical development pathways, defining indications, timing, combinations with existing therapies, but also robust clinical endpoints. And this will require close collaboration between clinicians, biologists, data scientists, regulators, and industry partners. At the ICH, we firmly believe that the microbiota-driven approaches will become an integral component of tomorrow's hematology, alongside cellular therapies, targeted agents, and immune therapies. The field is moving fast, and this is quite amazing. Thank you all for your engagement. I do apologize. We could not handle all questions, but I'm sure you can send an email to the speakers and moderators. Thank you for your commitment to shaping the next chapter of innovation in hematology. Wherever you are, please stay safe and keep well. This is the International Academy for Clinical Hematology around the globe and across the hematology field. Take care.